Hello everyone, welcome to the webinar. My name is Julie Hashida and I'll be acting as moderator for today's webinar on the topic of public entity healthcare for the homeless grantees and co-applicant arrangements. This is a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration Office of Special Population Health. This webinar is in response to a request for technical assistance from HRSA on behalf of two public entity HCH grantees who we've invited to this live webinar. Out of the 248 HCH grantees, about 20 are public entity programs, and we see this potentially being a topic of interest for the other public entity programs in the future. So that's another reason why we are recording the presentation. For this technical assistance event today, we've invited three speakers. Pamela Byrnes is a senior consultant with John Snow Incorporated. She will go over the nuts and bolts of co-applicant arrangements and the public entity programs. We've also invited two peers from the HCH field who have successfully gone through the process of developing their co-applicant agreement. We've asked them to talk a little bit about their programs and their setup and to share their experience of the whole co-applicant arrangement process and to share some tips and other insight. Dan Reid, who is the Assistant Deputy Director at Santa Barbara County HCH, will discuss their experiences at Santa Barbara County. And then we'll have Honor Potvin, who's Associate Director at Genesee Health System in Flint, Michigan, and she will go over their experience in Genesee. So at this point, I would like to turn the mic over to Pam. Pam?
Thank you, Julie. I appreciate that. Thank you very much for inviting me, and hello to everybody. I'm really pleased to be here, and to just say up front, this is without a doubt one of the more complex topics that we in the health center movement get to deal with. As a matter of fact, HRSA and the Bureau have recently asked NAC, the National Association of Community Health Centers, to do a monograph on public health centers, what the rules are, what the process is, and also kind of the good, the bad, and the ugly, best practices, not so best practices. And that contract actually has been given to JSI, and I'll be working on it with Pat Fairchild. So our conversations today will certainly be informative, and we may well be contacting folks back again. To Dan and Honor, you may have gotten yourself in trouble here for further follow-through on actually being a part of that monograph development. I'll start out by saying that I've pretty much seen it all in my years of working at NAC and with the other health centers around the country. There are very diverse ways that folks have put together public health centers, and even though I'm going to walk through pretty much what the expectations, the rules are, and the constraints, as with all other things in the health center movement, there have been some very creative, both positive and negative, ways that this has been done. I'd like to think of it in some ways as, and I got this from my friend and colleague Marcy Zackheim from Feldman Tucker, Life or Fidel law firm. She described it to me once as Fred Astaire and Ginger Rogers on a dance floor, and the struggle to dance smoothly, stay in with the beat of the music and the tempo, not step on each other's toes, and to respect the fact that once they leave the dance floor, they're no longer partners, and they can go their merry ways. And I've always thought of that as a very grounding concept when talking about this. So just to generally very quickly go through, an F2HC, a federally qualified health center, is a provider type under Medicaid and Medicare. There are basically, you can be a private not-for-profit, you can be a public entity, and we're going to talk about what that is, or an organization that's operated by a tribe or a tribal organization under the Indian Self-Determination Act or receiving funds under Title V of the Indian Healthcare Improvement Act. Having those designations allows you many benefits, as you know, but it also carries with it obligations and responsibilities and requirements, and we're going to focus in really only on those that pertain to the public entity model. The authorizing legislation allows for grant awards and look-alike designation for public and nonprofit entities. It does limit the amount of funding, 5% of the appropriation in any fiscal year that can go to public health centers, which doesn't apply to homeless and public housing. Because of the way the legislation was originally written, it didn't exclude overtly homeless and public housing grantees or lookalikes. However, it did not either overtly include them. So therefore, there are some allowances for organizations that solely receive funding or designation under homeless and or public housing. However, other than that, there's really not much that's said in the legislation, in the statute, in the regulations, in almost anything about really what it has to be or look like. And that's been a source of confusion for many, many years in the health center movement. It has general, it directs generally to the ability of a public agency that's engaged as a FQHC to establish general policies, but beyond that, it's never really gone much further as far as being specific. The one policy information notice that came out, I think it was last year or the year before, that actually for the first time defined what a public agency is, that's recognized as a public agency under the Community Health Center program. We are hopeful that the governance policy information notice that was drafted up a couple years ago may actually get out the door, because that will go a whole lot farther in really getting specific and giving folks on the ground the tools that they need to be able to really understand what it is they have to do. So at the moment, we're still doing the breaststroke. The Public Health Service Act includes 4 sections, 330E, that's for all underserved people in a defined geographic area. 330G for migrant and seasonal agricultural workers. 330H are services to homeless individuals and their families. And 330I are for residents of public housing. The reason it's important to know that is because there are special provisions that we're going to talk about in terms of the composition of the governing board, the co-applicant board, under this model and in general, that are allowed for the special population grantees or designees only. Once any 330E activity comes into the process, and Dan will address this since they went through the change from being only a 330H to also taking on E, once you go through that change, those exceptions are no longer applicable. So it's important to understand those differences. So just to back up for a second, the general rules for all health centers are that a health center that's funded by HRSA or designated as a lookalike must have at least 51% of the board members who are consumers of the health center services. A consumer for board member purposes is defined as someone who uses the health center as their primary source of health care. It's not judged by one entry in a medical record a year or the Medicare definition of once every 2 years. It's really meant because the people who use the health center should drive the bus, and that's why we're so successful as healthcare providers in terms of our positive outcomes and our ability to provide quality health care. It must have at least 9, but no more than 25 members. I always say don't go with 9. 1 drops off and you're out of compliance, and 25 would drive any executive director crazy to have to respond to that many people. So probably somewhere in between is a really good place to go, depending on how large your health center is, how many satellites you have, how many different populations you're represented or funded or designated for that you want to make sure that you have representation on the board from, but really trying to keep it in a reasonable size. No more than half of the non-consumer board members can earn 10% or more of their incomes from healthcare-related industries, defined extraordinarily broadly. If you're a consumer, which also, by the way, includes parents, legal guardians, foster parents, court-appointed caretakers, and court-appointed or legal sponsors of legal immigrants can also stand in as the consumer board member if the person that they're designated as a caretaker of or a parent of is a consumer of the health center services. So a mom, a dad, if you're designated in litem for your adult parent, any of those relationships, you could also be considered the consumer. If you're a consumer, it doesn't matter how you earn your income. But if you're not, there's a cap on the ability to have the number of health industry earners that you can actually have on the board. That's to make sure that the consumers are driving the bus and that, in fact, the board isn't, if you will, being unduly influenced by people who have an investment in the health care environment, the healthcare industry. It's defined very broadly. It's everything from the dentist to the receptionist in the dentist's office, the public health director, anyone who earns an income related to the healthcare industry. You have to have a conflict of interest policy. Blood or marriage-related children, spouses, in-laws of children or spouses cannot be members of the health center. And as it says here, you should at least have enough members to be representative of those populations you serve. These governance rules do not apply to tribal health centers because they're sovereign entities. And migrant, homeless, public housing in rural areas can actually apply for a good cause waiver that will allow them to waive out of potentially two of the requirements. The first one is the 51% consumer majority, and the second one is monthly board meetings. However, if you do receive a waiver for any of these, you do have to have an alternate mechanism by which you're receiving input and having communication with in the form of an advisory committee or some other mechanism so that you actually have an ongoing communication with the population that you're designated or funded to serve. So there always has to be that vehicle of communication even if you do get a waiver. But once you have any 330E activity going on, either through your designation or through your funding streams, you cannot get any waivers at all. All other statutory responsibilities must be fulfilled. So as I said, in the last 2 years, the feds have finally come across with some definitions of what a public agency is. A lot of this came about because we've seen a lot of changes in local government structures, the development of quasi-public agencies, the spin-off of some health departments into these quasi-public agencies, places such as Texas that have hospital districts, which actually are taxing districts. The questions of, well, who really is or isn't a public entity came up. And there is a pin, the number of which I apologize, I'll get it for you after, where you can go look and it will tell you the exact kind of documentation from the Internal Revenue Service that you have to be able to produce in order to qualify under the health center program. And of course, again, tribal organizations don't have to go through that because they're sovereign entities. So there are two different ways that a public agency, a public entity, can qualify to be a public health center. First of all, you could actually have the case where your board meets the composition requirements of the Section 330 program, and that has been known to happen. It happens also frequently if it's a special population only where you have the opportunity to apply for a composition waiver, in which case the board of the health center would be able to stand in for, or the board of the public health agency or any public agency would be able to stand in for that health center board. If that's not the case, which is the most usual situation, you have to form what's called a co-applicant arrangement. And that's where you have the public agency as half of the health center and the other half being made up by a totally compliant board of directors of the health center, which is known as the co-applicant board. The only time you can have a co-applicant board is in the public health center situation. We've had other organizations come in and go, well, I'm going to have a hospital and, you know, that private hospital is going to have a compliant co-applicant board and we're going to be co-applicants together. It doesn't work that way. It's only for public agencies. And we're going to go through and we're going to talk in a few minutes more detail about exactly who does what under that arrangement. Basically, this was done because the statute allows for public agencies, public entities to be able to take advantage of the opportunities and for their communities to be able to benefit from the advantages that having a community health center or federally qualified health center would bring to them in terms of access to health care. However, it also, on the other side, says we understand that you can't give away all of your activities, that there are laws in your state, there are laws in your county, you have to retain control of finance and personnel, but at the same time you have to be the square peg because only square pegs really fit in the square hole that the FQHC, the Community Health Center program, is. So it's kind of a, as my mother-in-law would have said, whack up the roles so that together we comply with everything we have to, both on the public side and on the health center side as well. And there are certain authorities that the co-applicant board absolutely has to retain control over, and we'll talk about those. So this is what it looks like, and I'm going to skip to the next one so you can actually see it graphically. The health center is both the public agency and the co-applicant governing board. The public entity is the grantee, or in the lookalike situation, the designee. It's the licensed provider, most typically. It generally establishes financial management and control systems. It most often establishes personnel policies because it is most frequently the case that all of the staff of the health center will in fact be employees of the public agency. The co-applicant governing board, which is very encouraged to be independently incorporated as a not-for-profit 501c3 for a number of reasons. One reason is because that way it actually exists legally as an entity and it has the right to sign contracts and other things. It also carries with it the corporate shield for the board members. And it also tends to add a better air of legitimacy that there's two equals who are entering into a partnership together, and they both have legal standing and they both have a place at the table in a more formalized way. So the co-applicant board is the one that has to comply with all of the Section 330 requirements, composition, selection, etc. It maintains the key authorities, which we're about to talk about, and in some situations it does actually employ the staff and the management of the health center itself. So what is the public entity side of its responsibility? And as you saw there in red, they are tied together by what's called the co-applicant agreement, and we're going to go into that in a little more depth in a little bit. You have to have, it is a must, not a should, you must have a co-applicant written agreement in order to qualify as a public center, and it must be approved by HRSA. So the grantee is the public agency. They're the grantee of record or the designee of record. They generally, as I said, provide are the licensed provider and employ the staff. They may establish financial management policies and control systems. They may arrange for the annual audit, but approving the audit firm and officially accepting the audit are statutory requirements of the co-applicant board. The public entity may develop and approve the annual operating budgets, but it must then go to the co-applicant board for final approval. It's the same thing with determining the general policies over hours, days, services, the schedule of discounts, charges, eligibility process for developing and implementing your sliding fee scale. All of those can be developed by the public entity, but in the end, the co-applicant board has to give approval to those because they retain the overall authority over those activities. They may also, most commonly, the public entity, because they usually employ all of the staff, does all of the personnel policies. They select, evaluate, and dismiss the staff other than the executive director, who, in the end, the co-applicant board retains the authority over whether or not that individual will continue to be the executive director of the health center. I'll just stop for a minute to say that this is one of the areas that we have some of the greatest difficulty, because if the staff technically works for the public entity and the health center co-applicant board technically has the authority to make the decision as to whether specific individual can hold the job of executive director or CEO of the health center, it really can create tense situation both for that executive director because they basically end up working for two people, two organizations, and also because in the end, whoever employs you truly holds the strings as to whether you stay employed or not. So even though ideally the board, the co-applicant board, and the public entity together would interview candidates and make a joint decision about who seemed to be most appropriate, and if that person wasn't working out, the co-applicant board could say to the employer, the public entity, you need to get this person out of here. It's still, they work for the public entity. In reverse, the co-applicant board can be very happy with the executive director, and maybe the public entity, and I've seen this happen, doesn't really like the autonomy that that executive director is displaying. And so they find other reasons why that executive director can no longer be an employee of the public entity, in which case by de facto they no longer would be the executive director of the health center. So those are the kind of difficult tensions sometimes that come up that we really want to look in advance before we get into this and say, how are we going to work out all of these issues so that it actually works? There are several cases, not a lot, not the majority, but in a minority of cases, the co-applicant board, the health center, actually does directly employ all the staff, which has its benefits and its detriments as well. The co-applicant board functions as the governing body for the health center project. If you think about it, this is like a bubble inside of the overall public agency or public entity. And inside that bubble, it acts as an autonomous living organism. Even though it's inside of the larger body, if you will, it has a life of its own, and the FQHC board, the co-applicant board, is the one that runs the show on the inside. That board must be compliant. It cannot have immediate family members of employees, and that includes in-laws of employees as voting members of the board. That includes, therefore, anyone who is an employee of the public entity, because the public entity is actually the grantee or the designee. The public entity can get involved in board selection and composition, but appointed members cannot be a majority of the board. They cannot be a majority of the non-consumer board members. They cannot be a majority of the executive committee, and they cannot be the chairperson of the board. The co-applicant board has to hold monthly meetings. That's the requirement unless you get a waiver, and I understand that if that new government's PIN ever comes out, which we all hope it does soon, that it's very likely that the monthly meeting waiver is going to go away anyway for everybody. The co-applicant board has to approve the annual grant application and the budget or the lookalike recertification. They have to approve, evaluate, and if necessary, request the dismissal or removal of the executive director, and then all of the other authorities that in the end they need to provide final approval for. You'll notice that the double asterisk refers to the H and the I, the homeless and the public housing. Again, that was a case of not specifically naming as opposed to not wanting them to do that. So it is preferred that all health center grantees or lookalike designees abide by these requirements. The co-applicant board, as I said, has to maintain all of their key authorities. We pretty much went through all of these. Any kind of changes, making changes in scope of project, which Dan is going to talk about when he goes over what they've done at their health center, all of them have to have final approval by the co-applicant board. I think we talked about this. I guess I put in 2 slides. Sorry about that. The public entity, it's important to note, cannot maintain overriding approval or veto authority over the board's activities. So, worst case scenarios, I guess I always bring up examples that aren't the best of all worlds, but one of the public agencies I was at, public health centers, the health center board had no control over the budget, down to the point where they couldn't have a staff appreciation pizza lunch without the finance director of the health department, the grantee in this case, signing off on it. There was no ability, even once the budget was passed, And it even went to the point where there was a strategic planning process that, this happens to be a health department, that the county health department went through. And the first time the board, the co-applicant board, ever heard about it was the night that everyone was at the Board of Health meeting, and the Board of Health consultant was reporting on the strategic planning process that the Board of Health had gone through, which had a significant piece of it that had to do with the health center, and the health center board was never even informed that the process was going on. That's when we see, you know, really not how it's supposed to work. And again, I tend to point out the ones that don't work as well, because those are the ones that tend to rise to the surface and have to be dealt with. There are a lot of great folks out there who are doing it great. Shared roles and responsibilities, again, the key to it is active joint decision making before the final approval, that people are working together on an ongoing basis. Communication is what says it all. So there must be a written co-applicant agreement that's executed between the public agency, the grantee or designee, and the health center board, the co-applicant board, that divvies up, if you will, the governance, the operational activities and shared authorities, and the mutual obligations of the two parties. It has to be approved by HRSA, and it must be consistent with all health center regulations, including HRSA affiliation policies. It's separate from the bylaws. The bylaws and the articles of incorporation, though, have to be consistent with, and the co-applicant agreement has to be consistent with each other. So there has to be some kind of internal agreement between all those different documentations that give a consistent guidance to the relationship between the two parties in the public health center. The governance, again, as we talked about, has to be consistent with the 330 regulations. The authorities are described in great depth, and I'm not going to go through these because you're going to have access to them. But generally speaking, all of these operational activities will be divided up and clearly specified in the co-applicant agreement as to who's responsible for executing and for final approval of each of the activities that have to go on. Again, it works best if we do it together. It works least best when the co-applicant board is not taking an active role, as they are supposed to be in actually implementing their authorities, and when the public agency, the grantee or designee itself, is not treating the co-applicant board as an equal partner in this activity. Generally speaking, they'll collaborate. That's when it works best, deciding together what is the best thing for the patients, for the health centers, for the staff, and for the organizations. The key is clarity, being very, very specific about who's doing what under what conditions. It really works best when you have the key staff or key players involved in each side in constant communication with each other. It's the best thing is communication. So the best way, the public entity does the personnel policies and employs the staff. Together, they interview people, and even if all the people are employees of the public entity offers the opportunity for people to apply for the job. A group of final candidates is selected. Together, they get interviewed, and the co-applicant board selects from that group the person that they feel is best to do the job with them. When it works, it's great. The ability to integrate public health and primary care, leveraging resources, it can be a really wonderful thing. On the other hand, where there's a lack of integration, where the health center is not respected by the mothership, if you will, for being the really autonomous whole little body of bubble in there in that organization, when one of the biggest problems I see is when the executive director of the health center is also the public health director or the director in the public entity. And remember, these aren't just public health departments, they're public universities. I had a situation where it was the county commissioners, and boy, weren't they surprised to find out that they were actually technically the public entity, not the health department. And sometimes it's a matter of we don't even know for sure who is who. and have to figure that out. A lot of executive director role confusion, blurring of lines, lack of respect, these can all be avoided. So what causes the most problems? Butting heads, being in a power struggle, fighting with each other over who's going to do what, which is so easily avoided by having communication and teamwork. If you're talking all the time, if you're working together, this can work out great. But it really does require a lot of concerted attention to making sure that communication is maintained. I think that's all for now. Dan?
Thank you, Pam. I appreciate that. That was very interesting. So just a brief overview. My name is Dan Reid. I'm the Assistant Deputy Director here with Santa Barbara County Public Health Department. And my presentation, I'm going to go briefly over our process that we went forward with putting our co-application agreement in place and the formation of our Community Health Center Board. I also have Ralph Barbosa here with me, our program administrator, so if we get into some specific program questions, I'll probably turn it over to Ralph at that particular point. And just a brief overview of our program, our local program. So Santa Barbara County is a large rural county with some urban centers, mainly along the coastal line in the south part of the county and in our northwest part of the county. We operate 9 healthcare centers, 3 of which are satellite locations, and we also have 2 sub-grantees that provide additional healthcare centers for our patients, both in the South Coast area for Santa Barbara neighborhood clinics, including a dental clinic, and up in North County, the Marion Community Clinics. This is just a brief slide to show where we were in 2009 when we went forward with our process. And that process involved a project scope change. In 2009, we were a 330H grantee. We also had 2 Ryan White programs, a Part B and a Part C. We had about 4,000 to 5,000 patients, 10,000 to 15,000 annual visits. With the change in scope that we went through, starting in 2010, we became a 330E Community Health Center. We retained our 330H status. The Ryan White Part B changed here in California to what they call a HIV care and prevention program, and we retained our Part C. But our patient population went then from up to 32 to 35,000 with 110,000 to 120,000 annual visits. So you might want to wonder why we went through this change. Well, a lot of the reasons that we went through the change involved our patient care. The FQHC model was a model that we believed in and were actively practicing for our 330H, and we wanted to expand that to our entire patient population. Keep in mind that we were also providing these patients with services as we were the safety net provider here in Santa Barbara County. And we wanted to make sure that we could access some of the benefits of being an FQHC, such as the 340B drug discount program, to be able to offer those significant discounts to our entire patient population, and thereby to access more services and expand our services. We wanted to more formalize our Community Health Center Board. We had an advisory board for our 330H, but we wanted to make it more robust and to provide more input from our patients. And in case we wanted to look at medical malpractice by attaining the 330E status, we would be able to include all of our providers instead of only those providers that were providing care for our patients that were under the Ryan White program or the Health Care for the Homeless. And before I go too much further, I just wanted to explain that we are a public health department within a larger county setting. So for us, the co-application agreement as a public entity was going to be between our Board of Supervisors and the Public Health Department. In addition to that, there are 5 supervisory districts within the county, and we wanted to make sure that those districts were well represented on our Community Health Center Board. So we used the change in scope process, which expanded in 2009, to allow us to expand from a 330H all the way up to a 330E community health center. The first step that we did was to adopt a local ordinance. And so now this ordinance is part of our county code, and that ordinance established the co-application agreement, which defined a lot of the roles and responsibilities that Pam mentioned to you earlier. During the process that we were going forward with developing our ordinance, which involved quite a bit of time in getting that through our county council as well as hearings before our Board of Supervisors to get that adopted, we were doing that in the end of 2009. We were also at the same time recruiting our community and consumer board members, defining what the board and so forth was going to look like, and trying to get all of those pieces aligned. We established that for our Community Health Center board that we were going to have 13 board members, 8 of which would be consumers and 5 would be the community members. The community members are appointed, one from each of the supervisory districts, and those community members help us with our ongoing communication with our co-applicant, the Board of Supervisors, by reporting back to the board with the board members at each of those districts. And they represented a wide variety of financial, social services, and healthcare expertise. The community members, we wanted to make sure that we had a broad demographic representation as well as geographic representation, and those were our patients that were recruited by our health center administrators and were educated in regards to what their roles and responsibilities were well before we even put the ordinance before our Board of Supervisors. Once the ordinance was adopted, at the initial meeting of our Community Health Center Board, their first business was to elect their executive committee as well as to review and approve the bylaws and also approve our change in scope application that had to go to HRSA. So all of this work had to take place before we could even go forward with our change in scope application. Once we established the Community Health Center Board, we have regular ongoing monthly meetings, as Pamela had mentioned. The last thing that I'd like to share with you a little bit is about some of the lessons that we learned in going through this process. I mentioned here, for example, in regards to technical expertise, this was a very complex process trying to understand what are the various roles and responsibilities of each of the co-applicants. So we reached out to HRSA, we reached out to OSHPD, we reached out to NAC, and a variety of other entities that had gone forward before us, such as counties here in California that had these co-application agreements under a FQHC look-alike arrangement. Others that had gone forward, we were able to borrow from them some of their agreements, some of their bylaws to understand what were the various options that we had. Fostering relationships, by this I mean that we had to reach out to each of the Board of Supervisors, to the various representatives that we were nominating to participate in our board, as well as the other FQHCs in our area. It's required as part of these application processes that we want to make sure that we're reaching out to those community partners to make sure that they're in agreement or at least understand what we're doing in regards to our application process and the development of our Community Health Center Board. We also worked with the managed care plans here locally to make sure that they were on board and understood what we're doing and participating on our Community Health Center Board. The pre-planning and the ongoing communication, as Pamela mentioned, it takes a lot of time for the board members to get up to speed, to understand how our operations take place, as well as our Board of Supervisors to understand what their roles and responsibilities are. The other thing that I would recommend to you is that you bring in your legal counsel very early in the process and bring things to them on an ongoing basis so that they don't have a large amount of work to do all at the last minute. And they were very helpful in helping us craft our ordinance, and getting that before our Board of Supervisors with very little discussion. Also, they need to understand you need to understand exactly what your Board of Supervisors can legally delegate to your Community Health Center Board, and if there are conflicts, how those are going to be resolved. And the last thing that I would recommend is allowing some flexibility in regards to your board composition. You need to have that 51% majority in regards to consumer members, but also you have to keep in mind that you're going to have a quorum to be able to operate on an ongoing basis. So the board can be comprised of anywhere from 9 to 25 individuals. We chose 13 because we thought that that was a manageable amount. As I mentioned, we had one representative for the community members from each of our supervisory districts. So we have 8 consumer members, and that we felt gave us a good cross-representation, but also in the event that we had vacancies or in the event that not all of the members could make the various different meetings that we have, that we would be able to continue with the operations without having to go dark on any particular month. So that concludes my presentation, and I'd like to turn it over to Honor at this point.
Thanks, Dan. That was a really great presentation. So I am Honor Patton from Genesee. Well, I actually work for Genesee Health System, but I'll talk a little bit about Genesee Community Health Center, which is the health center that we just opened in October through a new access point grant. Here's a picture of it. There's our flyer, just for fun. So just a little history about how we got to this point. We were awarded new access point funding in June of 2012. We actually submitted our new access point proposal in December of 2010. So there was quite a long lag there that actually gave us a lot of time to work out some kinks that we had. We also were the recipient of a HCH Health Center planning grant in August, so that was really helpful. And we spent a lot of that time trying to figure out what it meant to be a co-applicant and be a public entity grantee. And it's just a really helpful piece in this puzzle. We received funding to open 2 small clinics. We are not a 330E. We just serve the homeless and residents of public housing are our 2 funding streams, the 330H and the 330I. So, and I won't use this term anymore, but we were Genesee County Community Mental Health when we did the co-applicant application with the Genesee Community Health Center Board. We have since broken off from the county, and we are now Genesee Health System. We are still a public entity, but we are separate from the county. This is just a snapshot of the the size of our clinics and who we're looking at serving. We anticipate having about 2,000 patients in the first year, and hopefully approaching about 4,000 by the end of the second year. And just a little snapshot, a lot of children who are homeless and a lot of first-time homeless in our community. Our public housing population is about 90% single mothers with children. And I work for Genesee Health System. We are a long-time service provider in our community. And just to give you a snapshot of kind of the size of our operation, I think the key thing here is that we share our CFO, our CIO, our human resources, and our quality department, and actually have quite a bit of other administrative support with the health center. So that's been an important piece of trying to understand the co-applicant arrangement that will be in place. On motivation, our CEO, Dan Russell, always says it seemed like a good idea at the time. We've been planning this for quite a while. There was a growing need in our community, and we were also propelled by a report that people with serious mental illness are dying 25 years earlier than the general population due to preventable chronic health conditions. We wanted to become a player in trying to reverse that, and we knew it was something that would be beneficial to our entire community. So we went down that road, and we were looking also, of course, for the enhanced payment for services in the 340B program so that we could be financially able to open up the safety net. So as we went through the process, we back in 2010 realized that we needed to do this co-applicant board. And when we originally started the recruitment process, we started with a consumer advisory board of people from our target population who we expected to be consumers of services. We were not providing services at that time, so just went to our target population and talked to people who agreed that they would be interested in receiving services when we did open. We were quite successful at that time and had a very large consumer advisory board. When I say very large, it was about 12 to 15 people. But they were very active. And we worked with them for about a year before we even submitted our NAP, so we were able to invite a number of them to be on the governing board of the health center so that we did have a consumer majority at the time of our application. Even though we had that consumer majority, we still asked for the governance waiver because we did realize the issues that we might have maintaining that consumer majority. And that was a really wise decision because in the delay between 2010 and actually receiving funding in 2012, we did lose quite a few of those consumers. We no longer had the consumer majority. And then during the planning grant year, a number of the board members actually formed the core of the work group that we did the planning with, and so that was really great. And that core still serves on our governing board today. We do struggle, I think, because of the complexities of a public entity co-applicant arrangement. We do struggle to maintain a full board. I think both consumers and non-consumers are a little bit overwhelmed by the complexity of it all. So I think when it comes to consumer board member strategies, we really feel that the model we're using where we identify people who would like to serve on a consumer advisory board, that allows people to get their feet wet and really see if this is something they want to commit themselves to. And then that's the pool of consumers that we pull from to form, invite people to apply to be on the health center governing board. And I think that is a really good arrangement for us. There's just a lot of positive interaction that happens, a lot of training opportunities, peer learning, and just I think it's a great environment for getting people ready to serve on the governing board. But it also, people who do not wish to serve on the governing board are still able to have a voice, and we do have a liaison set up where a consumer board member is also attending the consumer advisory board meetings and brings that information back to the rest of the full health center governing board. So I think that's working really well. It also gives us, among consumers, because these consumer advisory board meetings are very well received, I think it gives some positive word of mouth, and hopefully we'll keep our pool of consumers to draw from large enough. So I guess one other thing I would mention here is that sort of an unfortunate thing we're seeing is that as the consumer advisory board members become more stable and get housing and find employment, they often, the scheduling is a little different. When we're first working with people who are in shelters, like a daytime, meeting time works best. But once people are finding employment, a lot of times they are looking for an evening meeting time. So we're struggling with that right now. And we are engaging the health center staff and our core providers in the health center to help us keep that cap a large enough size. And then with the non-consumer board members, as I said, we have a core that's been with us since our early planning days, and that has been really, we wouldn't be able to be successful without that. So I think the idea of starting those relationships early is really key. To recruit for that initial set of board members, we just kind of did the typical, we sent info packets out to people that we identified in the community that we thought would be great to have representing, the different parts of our community. And it worked out quite well. We have been really responsive to the requests for training that our
both consumer and non-consumer board members have asked us for. We've been able to bring in the Primary Care Association to do board training. We've used materials online from the National Healthcare for the Homeless Council and the National Association of Community Health Centers. We've worked with Community Health Partners for Sustainability. They work with public housing grantees. They assisted us and subsidized some board members touring some public housing health centers. So that's been all really helpful for us. One thing we have struggled with, again, being so complex, is the time management at board meetings. We often, in the early days especially, went way over our scheduled times, and this was pretty frustrating for people, but at the same time they had so many questions they did stay around. Sometimes I think our longest meeting went about 3 hours and it was scheduled for 1 hour. So it's just something to keep in mind. If there's any way to kind of address questions maybe in advance of meetings, that might help keep people a little bit happier and reduce the amount of board member turnover. Because every time a board member turns over, you have to start that education process all over again. And then when it came to writing the co-applicant agreement, when we started down this road, we just had no idea what any of this meant. And we borrowed a template from another county in Michigan, and we thought we could just kind of revise it where it seemed to make sense. But it ended up being a really bad idea because we are very different from county health departments. Being a community mental health authority, we have a lot more autonomy than most county health departments do. So using that template just made it seem really complicated and a lot more complex than it actually needed to be, and it didn't represent our situation very well. So it actually led to a condition on our grant that our co-applicant agreement, I think the language specifically was that the lines of authority were out of compliance. So once we really took a look at it, well, at first we had no idea what that meant. And we were able to set up quite a few conversations with other public entity health centers and kind of look at some samples of other people's co-applicant agreements to try to figure out where we had gone wrong. And we were able to get our hands on a couple of really good examples that kind of clarified it all for us. And we even talked to Pam Byrnes as we were struggling to figure out what it meant. And we realized that our co-applicant agreement just really wasn't clear at all. So as we kind of just started from scratch, and we kind of saw the opportunity that we had in making our situation clear. Our final product ended up giving, we had the autonomy to really give pretty much all of the authority to the health center board. We did retain the right to use our existing finance and personnel policies, but this was something that was actually really agreeable by the health center board because, we are a long-standing agency and our policies, with some revision, worked out really well to not have to do that all, reinvent the wheel on those. So I think our board has worked really well. When I say our board, the public entity board has worked really well with the health center board in giving them the autonomy that the health center regulations expect them to have, and that's been a really nice relationship between the two. Just in terms of local politics, we did have to explain this to the county, and we were very transparent all along the way, and we did not meet really no resistance. I think our intentions have always been to expand the safety net, and that's about it. So it's hard to find fault with that. One thing that we expected, we really thought HRSA would just tell us exactly what we should put in the agreement. And we struggled with this at first, that they wouldn't just say, here, this is what you're missing from the agreement. But as we did more research, we realized that it's really not their place, and that's when the sort of aha moment happened, and we realized that part of the reason that they're writing the agreement is to illuminate our situation so that HRSA could evaluate its compliance. And we also realized that it could be a tool for us, and that we could really set up the way that the arrangement, we could shape it and make sure that it was on paper the way that we envisioned it in our minds. So it really was a really helpful experience to write this once we figured out what we were doing. And for the conclusion, it really is all about relationships, and we developed more relationships as we reached out to different public entities around the country and the different national councils. We also, it was about the relationships between the public entity staff and the health center board, and the new director that was hired for the health center. And I think that it's all working out really well because we put a lot of effort into that. We started this years ahead of time, and it still isn't easy. So I guess just don't expect it all to happen overnight. And I can't stress enough, I just think that the training and education when you're a public entity co-applicant, it takes a long time to understand. So I think having that in mind, that you're going to need that training, will help with the stability of the program. And, we just used the resources that were available. We used them often, and I highly recommend accessing all of the available resources that are out there, so that you can be a successful program.
Well, we do have all the presenters' contact information, so if you do think of anything afterwards, anyone on the call, an email, so just email me, and I'll be happy to forward those to the presenters. I just want to thank everyone for their time, and definitely thank the presenters. I think they did a great job explaining everything, and that's all I have on my end. So thank you all, and I hope you have a good evening.